Awesome. Thank you, guys. Welcome back from your break. Up next, we have trauma-informed model for LGBTQ plus health with Zander Keig, LCSW, public speaker and advocate with the transgender and veteran communities. Zander is a distinguished figure known for his work as a social worker, educator, public speaker, and advocate, particularly within the transgendered and veteran communities. He is a U.S. Coast Guard veteran and a licensed clinical social worker. Recognized nationally as a subject matter expert on transgender issues, Keig has decided much of his career to support transgender individuals, including active duty service members and veterans. He played an instrumental role in establishing and developing the Navy Medicine West Regional Transgender Care Team, where he managed a significant caseload of active duty service members navigating gender transitions from July 2016 to January 2019. Keig's contributions have earned him numerous accolades, including being named NASW National Social Worker of the Year and NASW California Social Worker of the Year. He's also the author and co-editor of several books focusing on the transgender experience, including the anthology Letters of My Brothers, Transitional Wisdom in Retrospect, and his memoir, The Third Space, A Nonconformist Guide to the Universe. Beyond his clinical and advocacy work, Keig is a public speaker and a workshop facilitator, frequently presenting on topics such as emotional intelligence, conflict resolution, social care, family caregiving, and cultural competency. He co-founded the LGBTQ Caregiver Center after his father developed dementia. He has been involved with various organizations, including the Transgender American Veterans Association, Braver Angels, and the Pro-Human Foundation. Keig is a first-generation American of Mexican heritage. His personal journey and professional expertise have made him a significant voice and resource in social work, LGBT advocacy, and veteran support. Zander, thanks for being here, and you can share your slides.
Absolutely. Thank you so much. It's really wonderful to be able to be here with everybody today. I hope everybody's doing well. So again, I'm Zander, licensed clinical social worker. I currently live in Oregon. I moved here just a couple of weeks ago. I'm still a Florida licensed clinical social worker. I am a trans man with a lesbian history, first generation Mexican American, first generation college graduate, and a disabled military veteran. So my most of my work experience was as a social worker was at the Department of Veterans Affairs and with the U.S. Navy. So have a lot of experience, as you just heard, working with those populations and also being a member of those populations as a veteran. So we're going to be talking about trauma-informed models for LGBTQ health. The good news is that there are a lot of models. There are so many models, I can't even present them all in our workshop today. But I wanted to at least give you a brief introduction to this idea or concept of trauma-informed. Not everybody knows what it is, where it comes from. So there is a government agency called SAMHSA, which is the Substance Abuse and Mental Health Services Administration, and this is how they define trauma: an event, series of events, or set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, and spiritual well-being. So that's how they define trauma when we are talking about trauma-informed care. So there are many models, as I just mentioned, that are specific for the LGBTQ community. Some were developed for our community, and some have been adapted or adapted from other models to fit the community. And so the idea is that we're going to be they focus on the unique experiences of the trauma, the discrimination, the marginalization that is faced by our population, the LGBTQ population, with an emphasis on creating safe spaces, affirming settings, and culturally competent care, right? That's the focus of these models. In addition to that, there's also trust building, agency promotion, and just the ability to use these models to tailor the interventions that we use to address a very specific intersectionality of identities and experiences. So that's what we're talking about when we're talking about trauma-informed care and models and how it intersects with LGBTQ health and people. What I'm going to do is I'm going to start off in just a second by running a couple of polls just to get better acquainted with who is in the audience today. I'm going to be talking about some of the principles and practices of trauma-informed care. And then I'm going to look at a handful of these models. Again, I had to select from a longer list that was available, but we'll be looking at just a few of them, maybe about 5 different models. And then we're going to wrap up. I'm going to offer some suggested implementation ideas for various healthcare settings, and then also have a Q&A. So let's go ahead and get started with the polls. Let's see if I can just, oh, I don't have access to the polls. So I did set up or send over some information about a couple of polls.
Yep, I am. Okay, let me just trying to get to the last question to go away so I can get to the other ones.
So I'll just go through what the polls are while we're doing that. So the first question is asking if you, as a attendee today, are you a member of the LGBTQ community? And if you are, what is your affiliation within the community? And for those of you who are not members of the LGBTQ community, I'm inquiring if you're actively engaged in advocacy or allyship with that's the number 2 question. So there should be a number 1 question before that one that's showing currently. And then the second question focuses more on the exposure to and engagement with our community. So we'll see if the question number 1 pops up.
Okay, I think we've got it.
Thank you so much. Yeah. So are you a member? Yes or no? If yes, how would you describe yourself? And if you're not, are you actively involved as an ally or an advocate to our community? And so we'll wait for people to respond to that. They'll close it and then show the results just so we know who's in the room. And I appreciate you running the polls. I thank you very much for that. Mine went away, so hopefully other people are still seeing them, responding to them, and we'll get to all see the results.
Oh, so
Yeah, it went away. So other people are saying it went away.
I will go ahead and share it then, I guess.
Yeah, keep it shared, and then once a significant number of people have responded, we can move on.
You should be seeing the results now, I think.
Okay, those are the final results. Okay, there are a few people still
44%.
saying it went away, so let's see.
Yeah.
Oh, okay, so it is now, this is the final version then. So let's see, we have 5 out of 29 people. So I know we have 70 people, so 29 responded. So if you didn't respond, maybe for the second one you can. So the majority of people are not a member of the community. For the few who are, they've selected gay, bisexual, trans, other, and we have an even split between being active as an ally or a advocate to the community. And then the second question is just asking you more about your exposure and engagement with the community. So if you want to put up poll number 2, poll number 2 hadn't come up yet. So yeah, I think the poll closed before everybody was able to select. So sorry, I'm seeing people in the chat. It closed very quickly. So maybe the next one will be able to stay open. It'll stay open just a little bit longer. We don't have too
Okay,
much
well, I'm
time.
relaunching it, so hopefully this one's going to work correctly.
Yeah, so poll number 2. There you go. So how often are you engaging with the LGBTQ community? How often? I think when I do polls, I can see there's like a tally of how many people, what percentage of people. So I think, when we get to about maybe a 70% or so, it'd be okay to close it just to save time. Just so we can get an understanding.
Okay, we're at about
Hopefully.
68%. Would you like me to close
Yeah.
the poll?
Yeah, let's just go. Yeah, thank you. And then should let you share it. So we can see, oh, went away. Maybe, okay, there we go. So yeah, pretty even split between frequently, often, and from time to time. So yeah, good. So we have, people in the room who are members of the community. Those of you who aren't are engaging. So thank you. Thank you for participating in that activity. And it's just helpful for me to know, it gives me an understanding of who's in the room. So let me go ahead and move on. We're going to and talk about some of the key principles and practices of the trauma-informed LGBTQ health models in particular, right? Again, the idea is to integrate an understanding of trauma and the prevalence of it and the impact of it, and particularly how it relates to the unique experience of LGBTQ plus people. Right. So the first is the recognizing trauma, right? It's about acknowledging that LGBTQ individuals are at a higher risk for trauma. And that is due to a lot of different factors, including experiences of violence, of discrimination, marginalization, rejection, lack of social support. Another of the key principles and practices is creating safety, right? The idea of being able to create safety. Oh, I'm going to close that. Create safety where we're going to prioritize the physical and emotional well-being in the interactions that we're having with members of the community as clinicians. And that includes things like creating a welcoming and inclusive environment. And that will look different for each of you when I get towards the end and I'm talking about things that you can implement, that will come up as well. Building trust, right? When we're using particular models that are tailored to the community in which we're working with, the population we're working with, we're better able to foster a sense of trust and build rapport with individuals, have more open communication, more transparency, and also just respecting self-determination, right? So in that trust building. There's also promoting agency and choice. What we want to do is be able to empower individuals to choose like the care and the treatment that is going to fit for them and their circumstances, their situation. Again, respecting that self-determination, the agency that our clients have up to whatever level of competency they are capable of. Promoting agency and choice, it's a little bit of redundancy, but of course, these things are all overlapping, right? Then culturally competent care, right? We want to be able to be sensitive, regardless of the population we're working with. We want to be able to be culturally competent, have cultural humility. We want to be able to understand cultural context and identities and experiences. We're not going to be able to know all of these things to the fullest extent, of course. We are going to be limited, but we can expose ourselves through engaging in community activities, attending various workshops like this to get a maybe a broader view versus the one or two people that you might know personally or the few people that you might be seeing in your practice or in your agency or in your setting, right? It's good to get a much broader look at the community. I like to say often that we are not a monolith. We all are very different people. Even if we're all in one of those categories, we're a lesbian in the lesbian category, or the gay, or the bi, or the trans, or the queer. We are very unique individuals, just like everyone is. All of you are, regardless of your identity groups as well. We want to be addressing minority stress, right? So minority stress is looking at the particular stressors and traumas that are unique to minority communities. So as the LGBT community, we're a minority community, but it's not exclusive to us. Minority stress is something that they look at. They look at research and they conduct studies on various minority groups. So it's not just us, but looking at it from our very specific perspective and the type of stigma and prejudice and discrimination that we might face. With these LGBTQ trauma-informed care models, the goal is to help us tailor our interventions so that to the population, right, to this community in particular, by adapting evidence-based interventions that meet the specific needs of the individuals with which we're working with, right, and their various intersecting identities. We want to focus on the strengths I'm a strengths-based clinician. Not everybody has that um, um, orientation, but the trauma-informed care models do have an emphasis on strengths and a focus on that. So highlighting resilience within our community, within each of us as an individual, and not solely focusing on our personal deficits and on the societal circumstances with which we're working in, right? Finding a way to build up on the individual resiliency in order to navigate through life as it is, not as we would like it to be. And then finally, collaboration, working collaboratively, right, with the individuals, with the families, with the communities with which our clients are engaging to promote overall well-being and healing. So these are the key principles and practices that are included in all of the different models that I'm going to be sharing with you. It's not even that they're just specific to these models. That's just that those are trauma-informed key principles and practices that have been adapted to our community. So I'm going to review just a few of the various trauma-informed models that have been adapted to our community or have been developed specifically for the community. So the first one is SAMHSA. Again, that's the Substance Abuse and Mental Health Services Administration in the federal government. And so they have what they call their 6 principles, and they're focusing specifically on LGBTQ health providers to be able to adapt in their settings. So they're asking people to think about safety, right? Physical and emotional safety, including protection from things like misgendering, which would be if your client is using a different pronoun from the one that you might assume that they would be using, to use it when you are interacting with them, or most often it's when you're talking about them with somebody else or when you're writing chart notes, things like that, right? Not outing your client to other members of the practice, perhaps. During care coordination, we do need to oftentimes talk about our clients with other members of the team, but we should probably get permission from the client to give all the information that might not necessarily be important for the conversation that we're having, right? And then also just being aware of our own bias so that we're not acting in a manner that is discriminatory or prejudicial or biased. We all have bias, right? Bias can be either in the positive or the negative, but we all have bias and we all have negative biases about people. That's just part of the human condition. So it's just a matter of being aware of it and challenging your own bias, but also not letting it seep into your interactions with the client. Trustworthiness and transparency, right? So this is encouraging clear, open communication, consistent use of the name and the pronouns that your client is using themselves and has asked you to use. And then also going through a very lengthy informed consent process, right? Making sure that your clients understand, what therapy is about or what case management is about, depending. I was a case manager, whatever it is that you're doing with this client, like making sure that, it's one thing to hand a person a piece of paper that says informed consent at the top, and it's in a stack of papers and people are just flipping through and signing. That's not actually informed consent. That's a person's signature on a document that says informed consent, right? Unless people are fully informed, they can't consent, even if they have full capacity to consent. Yes, technically, perhaps their signature on that piece of paper is consenting, but they haven't been informed. And in being informed goes beyond what can be read on a piece of paper. It's also the information that we can provide to make sure that people understand. At UC Berkeley, they have a health literacy lab, and they have determined that the informed consent documents that most of us sign are in medical terminology and legal terminology that most people do not fully comprehend, right? And so if the majority of people in this country are reading at the 8th grade level, the traditional informed consent documents are not understandable by most people. That doesn't mean they're not smart. It just means that it's in a kind of language, medical and legal, that most people don't understand fully. So it helps for us to go through an informed consent process with them one-on-one, verbally, in order to build that trustworthiness and have more transparency. The SAMHSA model also incorporates peer support. So involving peer workers, if you can, mentors, advocates, maybe doing referrals to agencies that provide those services, maybe doing warm handoffs to other people you know that could be a mentor or an advocate for your client if you don't have somebody like that or people like that already in your office, your agency, your company, your setting. Collaboration and mutuality, right? So not everybody does this, but it can be really helpful to do shared decision making with your clients, and being more of an ally to your client than an authority figure. I mean, technically, we are the ones with the license, and we are the ones that hold a lot of power and authority in that relationship, but we can bring some of that disparity or that gap down by being more involved in shared decision making with the client. Empowerment, voice, and choice. So this is supporting the autonomy of our clients in how they identify in their sexual orientation and their gender, how they express those things through their behaviors and their clothing and the medical options that they choose, the different health decisions that they make, right? So um, I would say not rubber stamping everything your client says they want to do. We wouldn't do that with anybody. We would, engage them in a conversation about, well, what do you know about that? How many people have you talked to about that? Where are you doing your research? What kinds of experiences do you think you'll have? How do you think people react? If they react negatively, how might you navigate that, right? So we want to be able to provide that kind of support. And then there's also the cultural, historical, and gender considerations. So this is in the SAMHSA model, they're asking us to acknowledge the impact of things like racism, colonialism, heteronormativity, transphobia. Um, so when we're working with the LGBTQ population, to keep those things in mind, they may be impacting your client. It's not a guarantee that they are, and even they might not be aware that they are. There might be a very mild impact that it's having. In some cases, it might be very severe, and everything in between. So this is the SAMHSA, again, Substance Abuse and Mental Health Services Administration, federal government. This is their approach, trauma-informed approach that's been adapted for LGBTQ, working with LGBTQ people. The next one is the transgender equity and trauma-informed care model. This was developed in 2020, and this model was created specifically, as you can tell, for working with transgender clients or trans, because maybe, within that category, there might be people who use a lot of different identity labels like genderqueer and non-binary and third gender and polygender and transsexual, and there's a whole lot of different terms, two-spirit. Maybe others, drop them in chat to share them with your colleagues here. So with this model, the trans equity and trauma-informed care model, they're starting off with looking at just recognizing the systemic trauma, right? So transphobia in society, the history of, and in some cases, the continuation of medical gatekeeping in order to access medical transition. By medical transition, I mean cross-sex hormones, or what people might also call gender-affirming hormones or hormone replacement therapy. There's a lot of different ways people talk about it in different settings, right? So medical gatekeeping, people either like psychotherapists, sometimes medical doctors, but oftentimes psychotherapists who would be that gatekeeper, who would say, I'm not going to refer you on. I'm not going to give you a letter that you can take to a medical provider to start hormones unless you meet all of this criteria. Now, The criteria that most people are asking people to meet comes from WPATH, World Professional Association for Transgender Health. They have been in existence since 1979. They were at the time called the Harry Benjamin International Gender Dysphoria Association. They created the standards of care for how to treat and how to work with trans individuals in 1979. That was version 1. We're currently on version 8. And so following the WPATH standards of care can be considered gatekeeping by some people who want to be able to access the medical services that they want to access without having to adhere to any criteria. But uniformly, globally, WPATH standards of care are the gold standard for the bare minimums that people might want to take into consideration before they start a medical transition. So if you're not familiar, it's wpath.org. You can check out the standards of care. It's been translated into many, many languages and continues to be. In this model, it's about centering gender-affirming care and how that can be trauma reducing. Right? Very often, right, as a trans man myself, I transitioned 20 years ago, so things have changed considerably over the last 20 years. But this idea of gender affirming is just not pushing back on, not disagreeing with, not challenging in a critical way that what somebody is saying about what their gender identity is or how they're expressing their gender, even if they're not trans, right? Lots of people have gender expression that doesn't align in the way that people would assume based on what their sex is, right? There's a variety of masculine expressions that women have and a variety of feminine expressions that men have, and vice versa. So it can be trauma reducing to affirm the gender that your client is identifying with, is making statements and claims about, because they might be experiencing a lot of rejection and prejudice all around them. And so in that room with you, you can help reduce that trauma by not adding to it. Creating a trauma-informed organizational culture, right? So if you have the ability to, within your setting, to create more inclusive forms where you're asking for perhaps the sex, but also the gender identity of your client, or oftentimes what's most recommended is to ask the sex that's like listed on your birth certificate. Other people might refer to that as sex assigned at birth, right? Not everybody talks in that way. That's a very specific way of talking. I call it biological sex. Some people don't like that and they don't use that term, but I'm talking to you as like you're a broader audience and you're in a lot of different settings. And so people are going to be using different language in different settings, from medical settings to, community organizing, social justice settings to hospitals, right? There's a lot of different settings. And so can you change the forms to be more inclusive? Do you have gender neutral bathrooms or single occupancy bathrooms that your trans clients can use if they don't feel comfortable going into the single sexed bathrooms, right? I go into the men's bathroom. I don't have a problem with that. I've never had a problem with that. Nobody's ever bothered me. But not all trans people are comfortable with that. So are there other options? And that there's also just diverse staffing within your organizational setting. Right? We don't all have impact on that. It's not something we have control over, but if you do, these are things that you can implement that this model in particular is advocating for. And then just prioritizing trans-specific healing practices and community connections, right? So there are a lot of different ways with which trans people come together and celebrate and mourn and share, right? And so you don't need to know about all of those things, but it might be helpful to know about some trans people in the community, or some organizations in the community, or some events that happen in the community that you can share with your clients. Maybe get on some email lists. If they put out a flyer, maybe print it and have it available, right? So that you can let your client know. You can do a referral, a warm handoff. Sorry for using social work language. You can, I'm not sure all the different languaging that you use for when you send somebody somewhere else to someone else. But, prioritizing that their well-being and their ability to connect in with the community would be really helpful. The next model is healing justice framework, right? So the healing justice framework is rooted in Black and queer liberation movements. So when we say LGBTQ, the Q back in the day, in the 80s and 90s, was questioning, and then it turned into queer, and then we dropped the questioning. Sometimes there'd be two Qs. There's been a lot of change over the last few decades. In my experience, I'm almost 60 years old. And so the Black and queer liberation movements, right, that doesn't mean that all LGBTQ people are involved in or supportive of liberation movements. Many of us are involved in civil rights movements, right? There's Black civil rights, there's gay civil rights, there's also Black and queer liberation. These are kind of parallel movements that sometimes interconnect, but can remain very parallel. So this framework in particular comes from the liberation movement framework, right? This is not a clinical model per se, but it's more of an organizing principle of a holistic way of looking at your treatment that you're providing, your services, right? So this approach combines trauma-informed care with also what's called collective healing and social justice, right? So the core elements of this model are centering the lived experiences of LGBTQ people of color in particular, right? This because it's coming from Black and queer liberation. So this is a good model for LGBTQ people of color who are engaged in or supportive of liberation movements. Again, they might be more interested in the civil rights movement versus the liberation movement. But if you know that they are, you can tell them about both of these different models, liberation and civil rights. And, that's part of agency and decision making. It's also about recognizing historical traumas and intergenerational oppression, right? Because there's that intersection between being a person of color and also being an LGBT, a person within that community of LGBTQ plus, right? And so the historical traumas that have been experienced by your family and the intergenerational oppression that may have been experienced. It's also asking people to focus on culturally rooted healing. So bringing in things like art and somatics and spiritual practices that might be more appropriate or more understandable or more appreciated by your client, that's coming from the culture that they are part of or their family has come from, and maybe they've had a disconnection from that culture. That happens a lot, when you're raised in a pluralistic society. Some of our rooted culture is not as prominent, not as present, even within our family, right? And so, but we can seek those things out as therapists. We can provide opportunities for people to tap into that. And then also, just like the other models, right, with trauma-informed care, this is key to all of these models, which is promoting community resilience and mutual aid. So resilience, but not as just as an individual, but as a community, right, as a member of a particular community. And then mutual aid, this is there are many different options for where people can go and connect in with a community to get support, whether that's emotional or social or financial, informational support. So mutual aid is definitely something that you find in the more liberation movement communities, but not exclusively. It's also something that a lot of people are using to find the support that they need. Another one is the affirmative cognitive behavioral therapy model. So clearly this is an adapted model because cognitive behavioral therapy is a model that most of us, if not all of us, are already familiar with, whether we use it or not. But this is the affirmative model. So this combines traditional cognitive behavioral therapy with trauma-informed care practices and principles, and identity affirming practices, right? So it's going to be addressing internalized oppression and minority stress and trauma that's come from rejection, right? So oppression and minority stress and trauma, these are things, right, that have happened to us. And then we internalize some of those things to lesser and more severe degrees, right? For some people, they don't internalize at all, very little. And other people are very internalizing, right? They have a more external locus of control. The things that are happening around them impact them to a significant level. And other people have more of an internal locus of control, and those external things do not impact them to the same degree. It impacts them, but not in a way that might cause distress or dysfunction. Like it might in the other individuals. In this model in particular, it includes psychoeducation like CBT does, but it's focused on LGBTQ identity development. There are a handful of LGBTQ and trans-specific identity development models that I don't have time to go into, but so this is a model that sort of blends those identity development models with cognitive behavioral therapy. The last model I'm going to talk to you about is the minority stress model with the trauma-informed lens, right? So again, this is not specifically a trauma-informed care model like the liberation, or social justice, that healing justice framework was not clinical. This one is not trauma-informed on its own as a model. It integrates the minority stress model, which was developed in 2003 with the trauma-informed principles and practices that we covered to enhance LGBTQ plus settings, right? To enhance the type of services that we're providing. So it recognizes chronic stress that's caused by stigma, discrimination, and concealment, meaning not coming out, not disclosing, right? As we might have said, staying in the closet, right? So for gay and lesbian, bisexual people, they might have coming out stories. For trans people, we might use that same language. I say disclosure. Who do I don't disclose to, right? It's a little bit different with trans because we're talking about medical information oftentimes versus with sexual orientation. It's more talking about, who we're attracted to or who we're in relationship with, right? So they're not the same. A medical transition is a HIPAA protected body of knowledge. So a lot of us will say we disclose or we don't disclose or we low disclose versus are we out fully or out partially or are we in the closet, right? This is sort of a blending of sort of older ways of talking about it and newer ways of talking about it. This model or this lens also focuses on the protective factors, right? Because strengths-based, trauma-informed care models are strengths-based. So we're going to focus in this model on protective factors, encouraging identity pride, right? Helping people to connect into supportive communities, right? And identity pride can be helped along by learning more about those LGBTQ and trans-specific identity development models. Of course, I don't have resources for that. That's a whole nother topic, but they do exist. You should be able to find them pretty easily through Google Scholar or just a regular internet search. So that's that model. I said that there were many more models and I couldn't talk about all of them. Here are just a few other models that exist that are trauma informed that have been adapted for LGBTQ specific care. So the sanctuary model, that's a framework that emphasizes creating a safe and therapeutic environment within organizations. The ARC model, right, this focuses on attachment, regulation, and competency in ways that are particularly relevant to LGBTQ youth. So this is a model that is focused more on the youth end of our community, LGBTQ plus youth. The CARE model is a model that emphasizes collaboration, advocacy, resiliency, and empowerment. And then the trauma-informed affirmative care model is, I think I might have covered it. I'm sorry if I did. It's a framework. They combine the trauma-informed care principles and practices with an affirmative approach to LGBTQ plus identities and experiences. I don't think I did. I think I did the affirmative CBT model. So this is a or trauma-informed affirmative care model. So a lot of different models. I'll jump over to chat just really quickly. If there are any other models that you are familiar with, please do share them with everybody here so that people can look into them, right? I know people are going to get a copy of these slides. I also created a handout that people should have received that has these models on them. But if there are any other models, what else? What other models? So just share those. I'm not going to be looking at that. I'm gonna proceed on just for time's sake. But I want to be able to have people, share those different models with each other. Again, so many. And when I was doing research for this workshop, I didn't know that I would come across so many models. I was quite pleased that there are so many models available. More than I could cover today, which I think is good. So in addition to the interactions that you have with your LGBTQ plus clients or patients, here are some structural implementations to consider. This is whether you have the ability to make these changes on your own or not. Perhaps you have the ability to encourage, to suggest. Maybe you have an employee resource group or a business resource group or a council or a task force or something within your settings that allow you to work internally to make some structural changes. So what I would mention for implementation are just encourage staff training, right? Encourage whomever's in charge of deciding what the trainings are going to be for the year. See if you can connect with that person and encourage them. Maybe even have some suggested topics, some suggested presenters that can come in and do some training on LGBTQ plus topics like cultural humility, trauma-informed principles. What does LGBTQ plus even mean, right? Who are all these people, right? How do we all fit in? I'll often hear people say things like, oh, I'm an LGBTQ plus person. I find that hard to believe, that an individual person is at the same time lesbian, gay, bisexual, trans, and queer. Um, right? I personally know people who have been all of these things at different points in their life. That is not unusual. It's not as common, but it's not unusual. But to be all of these things all at once, perhaps we might run into that with a client who with DID, right, dissociative disorder, where maybe their different parts of themselves are members of these different communities, but like having somebody even just come in and just like pull it apart. Who are these people? What are we talking about? Right. And bringing in that cultural humility piece and the trauma informed piece. If you have the ability to draft inclusive policies and language by changing forms, maybe signage that's available in the office, right? Or again, if you can have some influence, if you can participate in the decision making of being able to draft inclusive policies and languaging in your setting. Also just be, are you able to create environments that cue safety, right? Are there visible images in your waiting room, in your lobby, in your office that signal that you're familiar with LGBTQ plus community or history or progress or movement or events, right? Do you have imagery that's up? Do you have books on your bookshelf that, as clients, they're always scanning the books, right? So do you have books? Do you have I know people, they put like little rainbow flag or or what's called the Progress Pride flag, or other kinds of flags. There's lots and lots of flags, right? There's non-binary flag and genderqueer flag and bi flag and trans flag and a lot of different flags. And so people will put that up, right? So it's not just the forms, but it's also those visible representations. Again, with the bathrooms, right? Can you convert all of your single sex bathrooms or single occupancy bathrooms into bathrooms that anybody can go into? Is there really a need to have a men's and a women's single occupancy bathroom? Can they just be bathrooms that have, you know, a sign on them that shows a toilet and the person in the wheelchair, right? That sign that goes on doors, that creates that more inclusive environment. Another implementation tactic would be to apply an intersectional lens, right? Not just to the work that you're doing individually or with, you know, couples and families, but in your organization, specifically within the structure of your workplace, right? Are people within your workplace in all the different ways that they can addressing how race and class and ability and immigration status and sexual orientation and all these different things affect the well-being of the people that are coming in to seek services, right? Whether this is healthcare services or psychotherapeutic services or case management or tutoring, whatever it is, right? Are people coming from that lens of understanding, but in a strengths-based way, in a resiliency way, not from this way of, because of all of these intersections, this person is doomed to be, you know, depressed or anxious. That is not necessarily the case. That's going to be on an individual basis, but that doesn't mean that we can't benefit from having an intersectional lens when we're looking at the different clients, customers, patients that we're serving. And then also another implementation suggestion would be to do ongoing evaluation within your setting, right? Regularly evaluating the effectiveness of the practices that are being implemented in your space, and then making adjustments as needed, right? You can do a training like this every day of the year and still end up at the end of the year with finding that it wasn't effective for certain members of your staff. And so what would be more effective for those members of the staff, right? And what kinds of conversations can we be having in a way that brings people in, right? We don't necessarily want to push people away from us or ostracize them or fire them because they have particular philosophical or religious or moral or whatever reasons with which these kinds of trainings are not going to cause them to implement these ideas. And how can we retain them and bring them in to the level of their comfort and ability to be able to serve our clients and patients and customers with dignity and respect, right? How can we all do that? Some of us are going to be welcoming and celebrating and encouraging. Not everybody is, but we can all be respectful. We can all treat people with dignity, right? We don't all have to be the kind of people who want to celebrate everything, right? That's, in some cases, that might be an imposing, you know, one person's idea of how to engage with a client or patient, and imposing that on another person, right? Does respect and dignity is good, right? I'm personally satisfied with that, and I would hope that a lot of people would be. The celebrating and the that we can, you know, if that's what you're comfortable with, please do it. But not everybody is, but we can find a way, right? We can find a way to bring most people in. Most people have a pro-human approach to life, and they want to treat people with dignity and respect. They just don't want to feel like they're being imposed upon to celebrate and encourage. And so we can be, hopefully we can tolerate dignity and respect from all of our colleagues and be satisfied with that. To wrap up, I'll do Q&A in just a second, but just to wrap up, I want to just do a summary of what I've covered. So we've talked about trauma-informed models for LGBTQ plus health integration, right? With an understanding of trauma, its prevalence, its impact, in particular, how it relates to the unique lives of LGBTQ plus people. So we've covered models that are emphasizing things like creating affirming and inclusive and safe environments that promote healing, that reduce the re-traumatization, that address health disparities that exist within our different systems, health system, education system, criminal justice system, right? The discrimination that people are experiencing, it's structural and also interpersonal and family levels. And then also just the intrapersonal trauma, right? The internalization of all of those external traumas and experiences that we pull in to ourselves. So again, a lot of information in a short period of time. And I couldn't go into a lot of detail, but I'm hopeful that the sort of the umbrella that I've created for you of all the different models that are available can be helpful for you, and you can do some further research on your own time. So are there any questions? I don't know. Are we using chat for questions, or is there a Q&A? Looks like we're using chat.
And so there's going to be a Q&A also. There's one question in there if you want to take a look at that right now.
Let me see. Do I see Q&A? Let me go to more. There it is. Q&A. So the question is, has anyone done a trans trauma biopsychosocial model? Wouldn't this be the most comprehensive model to tailor to each individual and to each set of circumstances? There are lots and lots of different biopsychosocial assessments that that have been developed, which would be, I think, would be incorporated into a biopsychosocial model. The models that I presented and the ones that I just also mentioned, some of them may have the foundation of biopsychosocial. Most of them are coming from a healthcare setting perspective. And so I might have used a little more language than necessary, emphasizing the clinical, but all of the models are coming from that trauma-informed care model, which is healthcare setting primarily focused. As far as trans specifically, I'm not familiar, but if anybody is familiar with a trans-specific biopsychosocial model, please drop it into chat so that we can all, check it out. And thank you for that question. Appreciate that.
Awesome. Zander,
Yeah, I mean,
have a
as a
question for
trans
you.
person, I'm looking for these things, but I don't run across them very often. So.
Zander, I have a question for you. As a social worker myself, is there a particular model you gravitate to or just find helpful in your practice?
So I don't currently have a practice. I spent my social work career as a clinical case manager, working with homeless veterans and transgender sailors and Marines and coasties, and then doing community care, clinical case management. So the model that we use, case management, we have our own models. And so none of them, and they are trauma informed. The work that I do now is I'm a psychoeducation workshop facilitator. I work with Lyra Health, before that Modern Health. So I present workshops like this, but more instructive in the corporate setting. So I don't use a clinical model in the work that I do. I work with groups of 50 to 500, and they're not intervention specific. They're psychoeducation tool and strategy building workshops.
Great. Thanks for sharing that. Are there any particular barriers that you've seen healthcare providers face when they're trying to apply these types of models?
Yeah, I think there are certain settings that emphasize a particular kind of model. Everybody in the practice is psychodynamic, or it's a DBT specific, clinic, or they can only use evidence-based, right? The very specific, when I worked at the VA, we were only allowed to use, and the military, we only allowed to use recognize evidence-based models, right? So that like healing justice framework, I don't know if that has gone through the rigorous, study to be identified as evidence-based. And so there might be challenges for people wanting to apply that. I would hope not, but that's what we run into. I'd say the other kind of barrier that can exist is a practitioner, a provider, assuming that we are, as LGBTQ people, a monolith. And so one model is going to work for all of us, right? Like I said, some of us take a more liberation perspective with our movement making involvement, and some take a civil rights. And so if a clinician or a provider is using, just coming from the lens of that more liberation mindset, it's not going to work with all of their clients or patients, right? It's or the people they're serving. So I can see how there can be structural barriers, but also barriers when we're interacting with the people we're serving, because we're utilizing the model that we like, but it doesn't necessarily work for the people we're working with.
That makes a lot of sense. Yeah. And one more question is, how do you envision trauma-informed LGBT care evolving in the next 5 or 10, 15 years?
Well, I would hope that more people would become aware of all of these different models that already exist, and maybe creating new models, like specifically that trans trauma biopsychosocial model, creating them, putting them through the rigorous testing, getting them become evidence-based, and so that people can start applying them in their different settings, right? So all these models exist, they're not new. So how do we increase awareness and the people adopting them into their settings? I'm sure a lot of people, they have sort of the intervention, right? They have their theoretical orientation and their specific intervention models that align with that. And then they're working with LGBTQ people, and they're piecing it together, and probably doing a wonderful job at it. But maybe there is a particular model that can complement what they're already doing. So just increasing the awareness and knowledge and the usage of the models that exist and creating new ones. I would hope that would, just over time, that would happen.
Great. Thank you so much. I appreciate it. It was so informative. Just being able to hear about all these models. Thank you.
Absolutely. You're very welcome. I'm seeing people in chat too, so I appreciate the feedback. Feel free to reach out to me if you have any additional questions, or questions that you wanted to ask, but you felt a little shy about putting into chat where everybody can see it. You don't need to be careful with the language you use. You can use any words you want when you reach out to me to ask a question. I don't want people to tell me how to talk, so I don't tell you how to talk. So use whatever language you want, which I hope I modeled that by saying things like, cross-sex hormones, gender-affirming hormones, and hormone replacement therapy. That's my way of saying I don't talk to just one particular person or people from one particular lens. I want everybody to feel when I use the word inclusion, I mean it broadly. Everybody's included. Even people who think that me as a trans person has done something wrong. I don't really care about that. I can still be friends with people like that. So, and I can work with people like that. So, that's my message for you. Reach out to me regardless of your perspective on this. Challenge me if you'd like as well. I appreciate that. So thank you, everybody.
Awesome. Awesome. Thanks again, Zander.
You're welcome.